Hello and welcome to the SHAPE antifungal webinar Diagnostic Pathways to Uncovering Invasive Mold Disease in Complex Patient Scenarios. I am a chief of the Department of Clinical Mycology, Allergy and Immunology in Northwestern State Medical University, St. Petersburg, Russia. And my co-speaker is Dr. Ashok Korup from the Department of Infectious Diseases, Mount Elizabeth Hospital, Singapore. The relevance of the topic of the webinar is due to the increase in the frequency of invasive mold diseases, mostly invasive aspergillosis and mucormycosis in different cohorts of patients. These are not only hematological patients with neutropenia, but also patients after solid organ transplantation, cancer, and pulmonary patients, as well as patients in the ICU, including those with COVID-19 and severe influenza. Invasive aspergillosis and mucormycosis are serious diseases with high mortality rate. Early diagnosis is essential for the successful treatment of these diseases. Our webinar consists of two presentations. I will talk about modern methods for diagnosing invasive aspergillosis and mucormycosis in different categories of patients, and Dr. Ashok Kurup will present a very interesting clinical case. So, I start my presentation, Diagnostic Pathways to Uncovering Invasive Mold Disease in Complex Patient Scenarios. It's my disclosure. In our registry, there are more than 900 patients with probable and proven invasive aspergillosis from different cities of Russia. You can see that we diagnose invasive aspergillosis mainly in adult hematological patients. It's important to understand that invasive aspergillosis can be a complication not only of acute leukemia. You can see that among the underlying hematological conditions, the number of acute leukemia and lymphoma is approximately the same. In non-hematological patients, invasive aspergillosis is most often diagnosed in patients with COVID-19, oncology and rheumatology diseases, solid organ transplants, and COPD. In adult hematological patients, invasive aspergillosis usually develops during neutropenia. In adult non-hematological patients, we rarely see neutropenia. In both groups, risk factors for the development of invasive aspergillosis are lymphocytopenia, the use of steroids and immunosuppressors, and transplantation of hematopoietic stem cells or solid organs. In both groups, the main locus of invasive aspergillosis is the lungs, but in non-neutropenic patients, we more often see several organ involvement, including the central nervous system. In our patients, the main method for diagnosing invasive aspergillosis is the galactomannan test, which works perfectly in bronchoalveolar lavage fluid. In neutropenic hematological patients, the galactomannan test is characterized by good sensitivity and specificity, but in patients without neutropenia, the serum galactomannan test sensitivity is low. In addition, the use of antifungals reduces the sensitivity of the galactomannan test. Therefore, according to the latest guidelines, screening for invasive aspergillosis with a serum or plasma galactomannan test is recommended for high-risk patients with prolonged neutropenia, not on anti-mold prophylaxis. In our pediatric patients, the galactomannan test in serum or bowel fluid is also the main method for laboratory diagnosis of invasive aspergillosis. However, in children with febrile neutropenia, the positive predictive value of the serum galactomannan test is low and may have false positive results. In addition, the sensitivity of serum galactomannan test is low in patients with invasive aspergillosis acute sinusitis. The BAL fluid galactomannan test is highly recommended for the diagnosis of invasive pulmonary aspergillosis. Galactomannan testing pathway is available on the website of the European Hematological Association. Serum galactomannan screening is recommended for high-risk patients with prolonged neutropenia, not on anti-mold prophylaxis. In other patients, a galactomannan test in BAL fluid is recommended if clinical or radiological suspicion of invasive pulmonary aspergillosis. New convenient and fast methods for laboratory diagnosis of invasive pulmonary aspergillosis are Aspergillus galactomannan lateral flow assay and Aspergillus lateral flow device. They have shown good sensitivity and specificity, especially in neutropenic hematological patients. But we must remember that the sensitivity of these tests also decreased with use of antifungals. The sensitivity and specificity of these tests in serum and BAL fluid are similar, but only lateral flow device offers true point-of-care diagnosis at the bedside without sample treatment. The use of galactomannan test combined with beta-D-glucan or lateral flow device test is beneficial for the diagnosis of invasive aspergillosis. According to this literature review, positive results of both galactomannan and beta-D-glucan assays or lateral flow device were in favor of confirming of invasive aspergillosis. Negative results of both galactomannan test and lateral flow device were beneficial to rule out the possibility of invasive aspergillosis. In our registry, there are 130 patients with probable and proven mucormycosis from different cities of Russia. You can see that we diagnose mucormycosis mainly in adult hematological patients. According to our data, mucormycosis develops in patients with more prolonged neutropenia and lymphocytopenia. Unlike isobuconazole, voriconazole is not active against mucormycosis pathogen. The main site of mucormycosis and aspergillosis is the lungs. In patients with mucormycosis, we more often see sinusitis and dissemination, including the central nervous system. Laboratory diagnostics of mucormycosis includes microscopy with calcofluor white culture and histology. molecular tests can be additional diagnostic methods. According to our analysis, sensitivity of molecular diagnostics of mucormycosis in hematological patients is 88%. According to modern guidelines, when diagnosing mucormycosis in hematological or diabetic patients, it's necessary to make a computed tomography of the chest, sinuses, and abdominal cavity to exclude dissemination. Then, it's necessary to obtain samples for microscopy, culture, histology, and molecular identification. The use of galactomannan test can also detect a co-infection. In conclusion, serum galactomannan screening twice a week is recommended only in neutropenic patients not receiving anti-mold prophylaxis. Serum galactomannan screening is not recommended in children with febrile neutropenia. The use of serum galactomannan test for the diagnosis of invasive pulmonary aspergillosis and disseminated aspergillosis is recommended only in patients with neutropenia. The use of galactomannan test in BAL fluid for the diagnosis of invasive pulmonary aspergillosis is recommended in pediatric and adult patients with and without neutropenia. Lateral flow assay and lateral flow device can be used to diagnose invasive pulmonary aspergillosis, but only lateral flow device offers true point-of-care diagnosis at the bedside without sample treatment. And molecular methods can be used to diagnose mucormycosis, and the use of galactomannan test can also detect a co-infection. Thank you very much for your attention. Dr. Kuru, please.
All right, thank you, Professor Nikolai. Okay, so it is now my privilege to discuss a case of a lung and skin syndrome in a vulnerable host to illustrate the use of appropriate diagnostics to reveal invasive mold disease. Okay, so this is a 34-year-old male who presented with pain over the right lower part of his back for 3 days, followed by a skin eruption, which we will come to. He reported no preceding fall or trauma. He had no fever. There was no pressure, either acupuncture or acupressure. There was no bites or scratches as well in that area. And in his systemic review, he reported having mild exertional dyspnea, which was of recent onset with no chest pains. He had no cough, no hemoptysis, no respiratory tract symptoms per se. His clinical history is relevant for acute myeloblastic leukemia, for which he was post-allo hematopoietic stem cell transplant 287 days prior. And so far, he had events as follows. He had chronic liver graft versus host disease. He had an episode of cytomegalovirus or CMV viremia, but there was no apparent end organ disease. And he also had carbapenem-resistant Klebsiella of the NDM phenotype with urinary colonization. His medications included the following, which was as follows: mycophenolic acid. He was also on ruxolitinib, which is a JAK1, JAK2 inhibitor used for sometimes steroid-resistant graft versus host disease, on prednisolone 20 milligrams twice daily, and his prophylaxis included posaconazole, letermovir for CMV, as well as his own clinician-derived prophylaxis for pneumocystis, which was clindamycin and primaquine. I believe the clinician was trying to avoid trimethoprim sulfur in view of potential cytopenias. On clinical examination, he was apyrexial and his blood pressure was within normal limits, but his oxygen saturation was slightly below at 94% on room air. He was Cushingoid, weighing 100 kilograms. Chest auscultation was unyielding, but what was most revealing was that particular area over the right lower lumbar, which showed a cutaneous eruption as shown over here, which measured approximately 3 by 4 centimeters in induration, and it had almost like a central eschar, if you will, which was discharging some minimal amount of hemoserous fluid. Investigations revealed hemoglobin of 10.7. He was not neutropenic. His white cell count was 3,400 with a polymorpho count of 94%. Platelets was low, 29,000. His C-reactive protein was 41. He had renal impairment with a creatinine of 127 micromoles. There was also evidence of some degree of transaminitis as well. A septic workup was done which included blood cultures, urine cultures, and all the cultures were reported as negative eventually. There was a sample from the hemoserous discharge from the skin eruption, which was sent for gram stain and culture, which turned out to be negative eventually. And a CMV DNA from the blood yielded a positive result, but a low count of 2.3 log. What was most significant was a chest X-ray, which showed the lesion highlighted on the arrow, which you can see is a crescentric cavity that you can see right in the mid zone. So at this point, we have a polling question for the audience. What would be the most likely diagnosis? Is this a case of ecthyma gangrenosum, possibly implicating Pseudomonas aeruginosa, with pneumonia, or disseminated staph aureus septicemia with possible endocarditis with embolization over the skin and lungs? Or is it C, is it tuberculosis, pulmonary disease with erythema induratum as manifest by the skin lesion? Or could this be disseminated fusariosis involving both the skin and lungs? Or is this a case of invasive pulmonary and cutaneous mucormycosis, or a case of invasive pulmonary and soft tissue aspergillosis? So could you kindly vote? And we will now try to give you a few moments and we will look at your results very soon. Okay, can we have a look at the results? I think the polling is still ongoing, but I think the audience are completely swayed away from bacterial pathology. I would think so as well. I think the majority are putting the bets on invasive aspergillosis, maybe the rest with muco and the minority for fusariosis. No one is buying the bacterial pathologies. And I think we can probably end the poll, and can we get back to the presentation? Okay, thank you very much. So I think that in this context, with the timetable of infection, if you will, after transplantation, it is quite evident that for bacterial pathologies, they tend to manifest earlier on. And this individual, unfortunately, has graft versus host disease and has immunosuppressants and so on. But the kinds of infections that we have to constantly deal with would be invasive fungal infections, so that is more likely. And in any case, blood cultures were sterile, that you would probably be positive for these entities of bacterial origin, as well as the culture of gram stain from the fluid, which was also negative. Fusariosis is also something that we would be able to get from positive blood cultures. And eventually the patient did undergo a bronchoscopy, which I will come to, and samples were sent for acid-fast bacilli and for PCR, and none of that came back positive as well. So we can more or less focus on E and F because those are the kinds of conditions that we can never know whether this is mucor or whether this is aspergillosis. In this regard, obviously the chest CT becomes very relevant because we know, and this has been published many times before as well, and when the patient is neutropenic, it becomes more evident that at diagnosis for invasive pulmonary aspergillosis, you might encounter nodules with or without the halo sign. And after a week, you might encounter them being nodules with the egg crescent sign or a cavitation evolving at 2 weeks. For mucor, you might see something this similar to aspergillosis, but you get to see more of the reversed halo sign, followed by the hypodense sign at 1 week, and at 2 weeks you see pleural effusions and cavitations evolving as well. You don't get to see the halo sign so much if you're non-neutropenic. But it's quite difficult to make that difference. This is the CT scan of our patient, and the arrows are highlighting obviously the cavity as well as the consolidation. And in this, you can't make the call between mucor as well as aspergillosis, but definitely you would think very highly of a fungal infections. Professor Nicolai had elaborated on the galactomannan antigen. So this becomes a consideration, but serum galactomannan would be limited in its utility here because the patient had been on posaconazole, and therefore it compromises the utility of it for its purpose of diagnosis in terms of sensitivity. So what do we have? We have the bronchoalveolar lavage, as alluded to, and we can use that. This is the latest EORTC, or the European Organization for Research and Treatment of Cancers guidelines for probable invasive pulmonary mold disease, and I can bring or highlight you to bronchoalveolar lavage fluid having cutoffs in that regard. And our patient, and this is our patient's result over here on the bottom right, and the galactomannan result was 3.61. So obviously, when we do the bronchoscopy, we would like to go and do all kinds of other things, including for cultures, and all these things were negative, and we didn't get any biopsy done because the patient's counts were low, and this is always a challenge in such patients. So we had to get surrogate markers like this to inform our diagnosis. So if we look back at published criteria on probable invasive pulmonary mold disease, and you can look at the reference and the latest guidelines from the EORTC, as well as the Mycosis Study Group Education and Research Consortium. And I apologize because there's a lot of data here, but you look at host factors on the left, you look at clinical features on the middle, and the mycologic evidence on the right. And you can see that our patient had fulfilled several criteria as far as his vulnerability was concerned for host factors, including components of being a graft versus host disease, treatment with immunosuppressants as elaborated earlier. He had clinical features of that cavity and consolidation, plus the bronchoalveolar lavage fluid showing the values as alluded to earlier. But obviously, we are not just going to deal with the lung. We have the cutaneous or the skin eruption as well, and he underwent a difficult surgery to get that out. It was pathology consistent with subcutaneous fat necrosis with an abscess with fungal hyphae, and the silver stain actually showed septations with acute angle branching of the hyphae, which is very characteristic for invasive aspergillosis, because for mucor you would see less septations and wide angle branching. So this is a case of proven invasive aspergillosis, both in the context of pulmonary disease as well as skin and soft tissue. And this is, again, criteria from the EORTC's latest guidelines telling us that if you have got pathology and it's clearly showing evidence of fungal infection, then you know you have got your diagnosis clinched. Other methods includes culture, obviously. Blood cultures, as alluded to, that's only specifically for, say, fusarium. And then tissue nucleic acid diagnosis, where you can amplify, if you have the diagnostics available, with perhaps DNA to try to do it by PCR as well. So we come to our next question. Now that we know that this is a proven invasive aspergillosis, what would be your preferred treatment? Would you choose voriconazole or liposomal amphotericin B or posaconazole or isavuconazole, or would you choose caspofungin? So can you vote now, please? And as you do that, maybe we can look at the polling, please. So it looks like it's a toss-up between voriconazole and isavuconazole with a smattering for posaconazole. Nobody wants to use liposomal amphotericin B. Wow, okay. Well, the majority is cashing in for isavuconazole. All right. So everyone's dumped liposomal. No one's keen for. Oh, look, we have some people for. All right. Okay. So the majority is for isavuconazole, and the minority for liposomal ampho-B, POSA, and Caspo, and the rest for voriconazole. Okay. Can we end the poll, please? Can we go back to the slide? All right. Thank you. So I think that, and we'll come to the guidelines and the recommendations in a bit, but it's quite obvious that from long ago, voriconazole has had some of the best data for invasive aspergillosis. But, the patient in this regard had renal impairment, which I didn't tell you this, but it progressed during the course of therapy. So it became more difficult to think of giving intravenous voriconazole because of the cyclodextrin vehicle, and for that same reason, liposomal amphotericin B. But liposomal amphotericin B would have been quite attractive because when you think about invasive mucormycosis, you would want to cover that, and sometimes we think of liposomal ampho-B as being a broader spectrum to cover both entities. Posaconazole had some recent trial data where it was compared with voriconazole, and it proved to be non-inferior for all-cause mortality up to day 42 for cases of invasive aspergillosis. But we didn't have the intravenous preparation here at that time of this patient, and he was already on previous prophylaxis with posaconazole, so we didn't use that one. Caspofungin would not be recommended as frontline or first line for invasive aspergillosis. So we do have an option with isavuconazole, and I will allude a bit to that in a bit. Okay, so we move on. But the managing team had chosen liposomal ampho-B for the reasons that I mentioned earlier. They wanted something broad spectrum, and they thought they could get away with his close monitoring of his renal function. They also threw in cefepime to have a broader gram-negative cover and some gram-positive cover as well. Unfortunately, these are his serial pictures taken of his wound, and he had debridement. There was very bad wound healing. He had a low-grade fever. He was getting a little septic. He was getting more breathless. We had to bring him in at that point to the intensive care unit, and then infectious diseases opinion was then requested. So I summarize his clinical course subsequently. So this is a gentleman who is unfortunate. He had vulnerabilities, and he had invasive pulmonary aspergillosis with a skin and soft tissue involvement. So the clinical therapeutics or management had to do with also with reduction of immunosuppression. When we switched him over to isavuconazole, like the majority of you audience pollsters out there, but then, we added in IV echinocandin in this case. Now, this is because the patient was quite sick. And this combination strategy was extrapolated from the study by Kiran Ma, which showed a higher survival in subgroups of patients with invasive aspergillosis who were given a combination of an azole and an echinocandin therapy. But then this is not really applicable, I guess, in all circumstances. I think this is very much on a case-by-case basis. Eventually, the patient improved. We switched him from the combination therapy to just isavuconazole monotherapy, and he made good progress, and I will show the next slide in that regard. And he was switched to oral isavuconazole and maintained on that subsequently. He remained stable for a while, less than 2 months, but unfortunately he developed complications from graft versus host disease, as well as other unrelated conditions, which I don't have time to come to in this talk. So this is his clinical course. The wound looks much healthier here with granulating tissue. And there was also resolution of the cavity, as you can see here, in the period of 4 to 6 weeks, and it's almost absent in the follow-up chest X-ray. So if we go back to the invasive aspergillosis treatment guidelines from various authorities, including the Infectious Diseases Society of America in 2016, it had put an A2 recommendation for isavuconazole, an A1 for voriconazole, and an A2 for liposomal amphotericin B. But this may change with time. So the characteristics of isavuconazole that was attractive overall, and in this case, was the fact that it has an excellent safety profile, almost similar to that of fluconazole. Unlike other azoles, it actually shortens the QT interval, not lengthens it, not specifically for this patient, but it's good to know that. It has both the IV as well as oral formulations, and that's good for step down eventually. And it has no cyclodextrin vehicle, as alluded to, something that's found in voriconazole, as this patient had renal impairment. So isavuconazole studies in invasive mold disease was studied in two: the VITAL study, which was a single-arm open label of 34 centers where mucormycosis was studied amongst the molds. And the cases were matched from a Fungiscope registry of patients who received amphotericin B. There were 37 patients had similar outcomes compared to ampho-B. In the SECURE trial, which was a phase 3 study that looked at allogeneic stem cell transplants who had suspected invasive fungal infections, who are randomized to isavuconazole or voriconazole, amongst close to 530 patients, similar outcomes were determined clinically, with adverse effects much more so in the voriconazole arm compared with isavuconazole. As far as duration of therapy is concerned, when we talk about these antifungal therapies, there's no hard and fixed rule, but we do have to pay attention to clinical and radiological responses, as well as resolution of neutropenia if it's present. Then we have to think about secondary prophylaxis. Not pertaining specifically to this patient who was previously on prophylaxis with a mold active agent, but serial monitoring of serum galactomannan can be used in the appropriate patient subpopulation. For example, in hematologic malignancies like stem cell transplants who have an elevated galactomannan at baseline, to monitor disease progression and therapeutic response and predict patient outcomes. And so there are good recommendations in this regard. So in summary, this is a case that illustrates a few teaching points, and one of that is that breakthrough of invasive aspergillosis can occur despite posaconazole prophylaxis. Of course, with the delayed release tablet preparations, we expect that levels should be fairly good in the blood, but sometimes it might be important to think about therapeutic drug monitoring or TDM, especially when it comes to absorption issues. When it's used for long-term prophylaxis, our patient was a gentleman who was weighing in excess of 100 kilograms, and he was becoming a little bit anorexic when interviewed at the time of his presentation, so that could have potentially been a problem. As well as the fact that, and we didn't allude to this, but you should know your own resistance background in terms of your fungal agents or elements rather, aspergillus and so on, because that's important in deciding specifically what kind of prophylaxis you should be using and what kind of therapeutics you should also be using. There's also some elements about prevention, which sometimes we tend to forget as busy clinicians. In this regard, this patient had unfortunately relocated to a new apartment, and he had done that with his wife a few weeks before the event. And you think that maybe that shouldn't have been and could have been avoided, because when you do that, you get exposures, environmental exposures that could have put him in a spin to acquisition of fungal infection. So in terms of diagnostics to establish invasive mold disease, we have discussed the futility of serum galactomannan when patients are already on azole prophylaxis, but we do know that we can use a utility or combination of other tests, which includes the good old CT chest and bronchoalveolar lavage galactomannan. If you have lesions that could be biopsied, you can, where possible, for example, in this gentleman with a skin eruption. Very hard to do that if the patient had a lung infiltrate, because a lot of times it's very difficult to do a transbronchial lung biopsy. We highlighted the use of isavuconazole in this patient, and it's important to choose that appropriately, correctly, to get the best kinds of outcomes. The advantages of using isavuconazole in patients with renal impairment, it's also got a good step down from IV to oral. That's rather neat. And it doesn't have that much of side effects, and a profile that includes shortened QTC. It's good to know that. Plus the need to continue to maintain suppression in a setting where you want to make sure that the patient has cleared the infection through and through. But there is one last thing that I wanted to leave the audience with, and that has to do with antifungal stewardship, an evolving field, because we spend a lot of time on antibiotic stewardship. But with antifungal stewardship, and we have newer agents as we have right now on the horizon, as well as with isavuconazole and so on, is to better understand its placement and to engage other instruments. For example, diagnostics. If we can do better with our diagnostics to get faster response, faster diagnostics, so that we know what exactly we are dealing with and which agent would work best, especially when you know what your own antibiogram, or rather what's your own resistance rates like. So it's important that you get the best diagnostics out. And also, where possible, with therapeutic drug monitoring, and you have got good accessibility to such tests, and that they come back in decent time, and you have got maybe good pharmacists who can also explain these things to you, because I think it's ultimately a combination of these things, plus the fact that you got adequate durations to kind of get the best out of antifungal stewardship. And with that, I thank you very much for your time.